Hello, everyone. I'm Dr. Robert Bayer, and I'm coming to you from the Living Well Cancer Resource Center in Geneva, Illinois. And I appreciate Angela and Sue, who are risking their lives to come film me for this, and they're staying their distance. As I said, I'm Dr. Robert Bayer. I'm a medical oncologist and hematologist with Northwestern Medicine. My area of specialty is hematology, bloodborne malignancies. I also do general medical oncology. The main hospital I work out of is Kishwaukee Hospital in DeKalb. I'm a Northwestern University alum. I've worked at many of the Chicago universities, University of Illinois, University of Chicago, Loyola. Sadly, not at Rush, but I have many friends across many health systems. I was fortunate enough to be involved in the initial building of the Living Well Cancer Resource Center. Living Well is a non-for-profit arm of Northwestern and is dedicated to cancer survivors and their families. It has over 100 free programs to help people cope with cancer and get through their cancer experience. So today I want to talk about immune therapies. So we'll first talk about general background in immunology, and then I'll go into the different therapies, the broad classes, and I hope to then answer some of your questions. So starting out with immunology, for those of you that haven't had a lot of experience or lectures on it, immune response is really a two-phase response. There's your innate immunity, and this is your immune system's response to attack, such as COVID and other viruses, bacteria, poisons, toxins. And then there's a second wave, which is called the adaptive immunologic response. In the adaptive response, the body has now identified the intruder and has a specific set of reactions that are much faster and much more thorough against the toxic or invading bacteria or virus. So we're in the era of COVID, and so you will hear much about immunology and the immune response to the virus, but I'm going to talk about the oncologic aspects of immunology and the adaptation of the immune response to fighting cancer, which has been extraordinary in the rapidity of development of new treatments in the last decade. So one of the things I wanted to point out is immunotherapies, which is using modification of your body's immune response to actually treat a malignancy. That is active through inflammation. And many patients, their ability to tolerate the immune therapy is dependent on how much inflammation is generated by the therapy and how they tolerate it, or any pre-existing inflammation that may predispose to side effects and complications from immunotherapy. When we talk about immune response, getting down into the effectors, the parts of the body, cells, antibodies, cytokines, iconicids, these are the proteins and cells that actually cause the immunologic response and the inflammation. Cytokines, and I'm going to look at my notes here, iconocytes are also referred to as prostaglandins. These are the proteins that are released in order to have the immune effector cells talk to each other. They stimulate the growth of cells that can fight the intruder, the cancer or the infective particle or toxin, and they also bring cells to the area where the fight is occurring. Leukotrienes are proteins that attract these effector cells. The first wave responders are typically neutrophils. So you'll see many oncologists looking at neutrophil counts before you start your therapies to make sure that they're adequate. If you're using cytotoxic or old-fashioned chemotherapy that damages the DNA and damages the membranes of fast-growing cells, you want to make sure that your frontline infection fighters aren't depleted too much, because then you become susceptible to opportunistic infections, again, like COVID, but other viruses, other bacteria, fungal organisms. It can be a broad range. Many of these organisms aren't common to us because our innate immune system keeps them at bay. So when our immunity falls, these common organisms find opportunity in infecting our host or our own bodies. Then some of the first immune therapies that were discovered were the interferons. And again, that's relevant today because interferons were initially discovered as a immunologic response to the common cold. And in the early days of immunology, there was a big search looking for ways to fight the common cold or prevent the common cold. And interferons inhibit protein synthesis and stop the virus from replicating itself within cells. However, interferons cause major immunologic reactions, fevers, shaking chills, muscle aches. These are all side effects of interferons. And so when you hear about toxicities or reactions to COVID, a lot of that is from the interferons that your body is releasing in order to fight the virus. Other biologically active proteins that the immune system releases are chemokines. Chemokines are a broad class of proteins that help cells move through the blood, lymph, and soft tissues to get to the area that's under attack by the foreign invader or toxin. Then come my favorite cells, the memory cells, which are now referred to as plasma cells. These are B lymphocytes. They're specialized cells that remember what diseases you've had before, like your childhood diseases or vaccinations. So if I've had measles or I've been vaccinated against measles, my plasma cells remember what that looked like, so that when I'm re-exposed to the measles, the response isn't just the innate response, but the more targeted adaptive response, and the response is much more targeted against measles and the infected cells, because measles reproduces inside normal cells. And so the immune reaction is against the transformed cell to prevent the virus from replicating and spreading throughout the body. And that's why vaccinations are such an important goal right now to fighting viruses. The hope is that we train the immune system to fight the invader before it can really take hold. Now, in oncology, there are tumor vaccines, the most famous of which are the vaccines, there are several now, against cervical cancer. Most cervical cancer is caused by the human papillomavirus, and particularly serotypes 16 and 18 transform or mutate cervical cancer cells from benign normal cells that line the cervix and turn them into a malignancy where they proliferate and they become immortal. Then, once these cells are auto-replicating, they spread throughout the body and can kill the host. There are cell lines from cervical cancer patients that are more than 40 years old, and they're still growing unchecked in laboratories all over the world and are used as a testing ground for new therapies. That's memory cells. Memory cells make the antibodies IgM, which is a non-specific antibody that is a huge molecule, and it's your first responder antibody to something that's new and novel. And then there's second line wave of IgG, which is short, fast, and more specific. And there are many different kinds of plasma cells geared towards many different kinds of invaders and targets. And so you have a polyclonal, basically, repertoire of antibodies that are then individually stimulated depending on what the attack is. So in multiple myeloma, you can have these memory cells or plasma cells mutate where they're no longer making an effective antibody but a fragment, and we look for that fragment in the bloodstream in order to tell us whether those mutated plasma cells are still alive and in our bodies. The next come the growth factors. The most common growth factor is GCSF, Udencia, Neulasta, Neupogen. There are different commercially available products, but these stimulate the precursor cells in the bone marrow to make the neutrophils, which are your responders. Now, sadly, the neutrophils don't have a big role in cancer therapy. They have a big role in preventing and controlling infection. But there was a related compound many years ago called GM-CSF, granulocyte macrophage colony stimulating factor, which not only stimulated the neutrophils to fight off infection, but stimulated macrophages, which had the ability to destroy tumor. And it was shown in the early days of melanoma therapy that injecting GM-CSF into tumors, sometimes you could get responses. And that was the beginnings of trying to understand the immune response that could control melanomas, which is a very lethal type of skin cancer. After the growth factors come complements. Complements, I consider those like drones. These are little fragments of cells. There's no DNA or RNA in these, but your immune system can release these, and that can harass an infecting organism. It can coat it, it can stimulate inflammation, and it can rip holes in the membrane of the cell and increase permeability of the vasculature and the lymph system to allow more fluid and inflammatory cells to invade. And it also ruptures those cells so that before a virus, for example, or a cancer can replicate in that cell, it dies. So those are some of the ways. Then there are the phagocytes. The phagocytes are your macrophages, some neutrophils, and dendritic cells. So basically, by phagocytosis, we're talking about cells that go and swallow up the infected or mutated cell, and then bring it inside and then beat it up. That's essentially what phagocytosis is. Now, my favorite in this class are the dendritic cells. Dendritic cells are really smart. They digest away the tumor or the infected cell, and then they preserve some of the antigens or proteins on the surface of the cell that can be used to mark the cell. And then they present that to the T cells and convert them into cytotoxic T cells or natural killer cells. And those are your assassins. They get out into the tissues and into the bloodstream and have the ability to go around looking for the ID cards of cells. Are you supposed to be here, or do you have a mutated antigen? And then if you do, I'm going to destroy you. And that's become a really major development in cancer therapy now, So many people, when they talk about immunotherapy, they're talking about unmasking the dendritic T cell interaction so that those T cells can go and do a number on the malignancy. So getting into how can you kill a cancer, let's get right to the basics. There's only a couple ways to kill a cancer without killing the host. One is mechanical, and these are where my surgical colleagues come in. To cut is a chance to cure is commonly discussed in locker rooms. Cold, hard steel, cutting a tumor, no matter what its biology is. But that really is only effective when you have a localizable disease process where you can get it out and get margins, and the disease has not spread yet. Sadly, many cancers in this world have already spread or are not confinable. So that makes the role and curability with a mechanical approach limited. Then we have radiation. Radiation causes necrosis and inflammation. And so it can be ionizing radiation, where you generate free radical oxygen, or ozone, if you will, and that can destroy membranes and cause a big immunologic and inflammatory response. And that's one way to kill the cancers. Then we have cytotoxics. These are the classic old chemotherapies that go and damage the DNA or damage the cell structure or affect the twisting and untwisting of the DNA, and they cause necrosis or, again, an inflammatory reaction that kills the cells. The problem with those is they're not targeted. They affect the inflammation, but what about areas where they may not penetrate, or the concentration may not be high enough, or they're destroying cells that are critical to our existence? That if we damage the friendly fire, your own healthy cells, then that may be worse than treating the cancer. So cytotoxic is a tool, but not always the golden, how shall I say, the golden bullet. Then there's apoptosis, one of my favorites. Apoptosis is programmed cell death, where there are proteins on the surface of most cells, cancer and non-cancer, that if you stimulate them, they send a death signal into the DNA of the cell, and the cell commits suicide. I like to think of this as Star Wars, that magic torpedo that hits the right spot and then triggers an explosion within the center of the Death Star, and the Death Star blows up. So that's apoptosis. Immunotherapies typically, in the majority of cases, do not work through apoptosis. The oral therapies and these small molecules that can trigger these proteins are the most common way to trigger apoptosis. So just a short list, since my time is limited here. Interferons, big inflammatory response. Antibodies, native response, but we can also generate monoclonal antibodies in the laboratory or from biologically modified animals, so that we have an antibody that will specifically target the invading or mutated cell. Then there's bone marrow transplants, transplants of different types. The classic would be the allogeneic bone marrow transplant, where you use chemotherapy or conditioning regimen to destroy as much cancer as possible. You destroy the host, the patient's own stem cells, but then they receive a transplant from a donor. What's fascinating is if those donor cells engraft, they actually then can make cells that destroy the cancer. So if the cancer wasn't destroyed by the conditioning regimen or the induction regimen, the last little bit of tumor can be destroyed by that new healthy immune system that recognizes the cancer as bad. And again, that's the T cells the natural killer cells that are doing the work. Then you have just immune stimulation. The classic one was the interleukin-2, which was used for kidney cancers and melanomas over 20 years ago. It's still an effective therapy, and in a small number of patients, it was curative no matter how far the kidney cancer or the melanoma spread. The problem was with interleukins that it would cause such a large inflammatory response that inflammation was fatal in many patients, or not strong enough to kill the cancer, and then the cancer would grow in a weakened host. And so we don't use interleukin-2 that much, only in select cases. What's becoming more interesting is what's called CAR T therapy, an adoptive T cell modification. And this can be quite toxic also. Right now it's predominantly used in leukemias and in refractory relapsed lymphomas, but it's being researched in many other types of cancer, including myelomas. And in CAR T therapy, this is after your disease has been refractory to standard chemotherapies. We stimulate your immune system, we harvest the T cells, modify them, and basically soup them up and give them back as an infusion, and then they go down and hunt down the cancers, causing a massive inflammatory response. That inflammatory response is frequently fatal, but as we've developed tools to control that inflammation, the CAR T therapy has become much safer, and we're able to get the highly effective immune response and prevent it from overrunning the host and overrunning the patient. So just one more word on COVID. What many of the deaths from COVID are due to is the inflammatory response to the virus. The virus gets into the body, it has those little spiky things that you see on all the diagrams on the evening news. They interact with a receptor on certain tissues like lung, heart muscle, kidney, and GI tract. They get into the cell wants to defend itself, so you have a huge inflammatory response. The body releases interferons, it releases interleukins, that affects blood pressure. It can stimulate the clotting system. All the inflammatory reactions will control the virus, but they frequently kill the host. And some people can tolerate this inflammation and others can't. And that's what you see in debilitated people. They have an inability to control that inflammation. So with that little taste of immunology, I wanted to answer some questions. And I'll start out with the questions I've received on the internet already. The first question is immunotherapy a good option for metastatic prostate cancer? What is tumor sequencing, and is it important to be done before starting immunotherapy? That's an excellent question. So prostate cancer is very common. It's one of the most common cancers in men. The problem with prostate cancer is there's a variety of different mutations. Some are more aggressive than others that are driving the prostate cancer in men. And immune therapy has not been the home run that we've seen in other malignancies. What's been much more effective with less side effects is ADT therapy, which is androgen deprivation therapy, or what we call hormone therapy, where we block down the body's testosterone and androgens from adrenal glands, and frequently the prostate cancer tumors, which depend on those androgens, become dormant or die. Since that's so effective with the least amount of side effects, that's generally the first choice in metastatic prostate cancer. Radiation and surgery are more appropriate for localized or palliative metastasis when you don't have much disease, but if you have large volume, ADT comes first. After ADT, one of the first immune therapies that was approved was Sipuleucel, I always butcher that name, T, which was an immune stimulant that was used in hormone refractory disease. And I'm sorry for the interruption, hormone refractory disease. The problem with it is it didn't control the PSA. So the PSA could go up even though you had a measurable response, and it wasn't as durable as a lot of other treatment options. So it's really fallen out of favor. And it's been replaced by the superandrogens like abiraterone or enzalutamide, which in combination with the androgen deprivation therapy have been extremely effective and can last for years. Then come the cytotoxics like the taxanes, taxotere, and paclitaxel. Those have been much more effective than the immune therapies in prostate cancer. Immune therapies are really reserved for second-line therapy when your front-line treatments aren't working. But they do have activity, it's just not ubiquitous. I hope that answers your question in a long-winded way. The second question here is having a Neulasta injection considered immunotherapy? As I mentioned earlier, Neulasta is a growth factor for neutrophils, and neutrophils typically, and there are a few exceptions, but typically fight infections and not tumors. The T cells are what you want to stimulate, and Neulasta doesn't stimulate T cells. So it's a biologic response modifier, but not an immune therapy against malignancy. Here's a question. I had immunotherapy treatment that ended in October 2019. For the last 3 months, I've been having issues like skin rashes, hypothyroidism, dry mouth, and no one can figure it out. Is it possible I have an overactive immune system? Yes, that's possible, but it can also be explained as a toxicity from other therapies that you may have had or other medications. Typically, if your immunotherapy stopped in October, it would be unusual for that still to have an activity today, but not impossible. Immune therapies can be self-stimulating. So sometimes you stimulate those T cells and they may change in number but never totally go away. So the answer is it's possible, but not conclusive. The fourth question I have is I developed pneumonitis after 3 sessions of generic Imfinzi. The other name for Imfinzi is durvalumab. It's commonly used in lung cancer. Anyway, Imfinzi immunotherapy after chemo and proton radiation. I had 2 additional immunotherapy sessions before it was stopped in late August 2019 due to level 2 pneumonitis. I was dropped from the immunotherapy program. I just touched my face, evil me. Immunotherapy program is high risk. I've been on prednisone since late August. I went off in December, but currently back on because of pneumonitis that started to develop again. I'm currently cancer-free and am being watched every 3 months with CAT scans and frequent lab work. Is there anything else that would be needed? I had a previous cancer years ago that involved extensive amounts of radiation to the chest. So there's a lot of sub-questions in that question, but let me briefly touch on pneumonitis. So pneumonitis is one of the more serious side effects to a lot of the immunotherapies, especially what we call the CHEK2 inhibitors. These are commercially available. I won't go into the commercial names, but you'll see them advertised a lot on television and radio. Nivolumab, pembrolizumab, durvalumab, there are several others on the market. And these work by going to the dendritic cell T cell interface, and a lot of tumors escape immune detection by your immune system by putting out these blocking proteins, PD-1, PD-L1, etc. So the dendritic cell's message to the T cell becomes blinded. The T cell doesn't receive or understand the message from the dendritic cell, so it never stimulates and goes after the cancer. These drugs, these CHEK2 inhibitors, remove that silencing signal so that the dendritic cell can tell the T cell what to look for and stimulate it, and then that natural killer cell can go hunt down the cancer anywhere, brain, skin, lung, liver, anywhere. And this was the concept behind former President Carter's melanoma. When it had gone to the brain and wasn't responding to anything, they gave him checkpoint inhibitors and T-cell stimulant drugs, and those natural killer cells put him into remission, and that's been durable. Now, the problem with that is you can't control those natural killer cells very easily. Those cells can go and do whatever they want, and you hope that they can recognize self from non-self. If they think that the cells that are part of you are the bad guys, they're going to attack and they're going to cause massive inflammation. And that's what pneumonitis is. It's inflammation of the lung. The problem is, how do you differentiate that autoimmune reaction from the T cells from an infection or inflammation from prior radiation or a reaction to prior chemotherapy like bleomycin, which classically causes permanent inflammation of the lung? So it's not easy. We make an assumption based on time and sequence. If I get one of those checkpoint inhibitors, let's say pembrolizumab today, and within the next week I can't breathe, and a CAT scan shows my lung full of inflammation, and testing shows no infection, then it's probably the pembrolizumab and the T cell reaction. Then we try to suppress the T cell reaction. Steroids are first line, but as you suppress the T cells, you're taking away the effector cell, the cell that actually is doing the heavy lifting and destroying the cancer. If that doesn't work, so this inflammation continues, and you're absolutely sure it's not an infection, because remember, opportunistic infections become common when you manipulate the immune system in a cancer patient. So you want to make sure you're not missing a virus. You want to make sure you're not missing an uncommon bacteria that's hard to culture, a fungus. So in those cases, we typically do a bronchoscopy with brushings and biopsy to see if that inflammation is truly, the pembrolizumab or whatever the CHEK2 inhibitor is, or whether there's an infection that we just didn't pick up. Now, we don't do this up front. We do this when empiric therapy, just giving antibiotics and watching, doesn't work. If everything works just by stopping the CHEK2 inhibitor, well, then you don't need to worry about it, except you can't come back to the CHEK2 inhibitor because of the side effect, so you go to something else. What if you're not sure and the side effect isn't so bad? You can re-challenge, and sometimes that's all you need to do. So I'm rambling here a bit. Let's move on to the next question. And what if you don't respond, and you don't respond to steroids or stopping the drug? You can use blocking antibodies. One of the commercial products is called Remicade. Ifitinib, I believe, is the generic name of it. Actually, Ifliximib is a generic name of a T-cell suppressant. And then mycophenolate, also commercially known as Cellcept, which is a pill. These are drugs that were developed for other diseases like Crohn's disease, but they have the ability to suppress the T cells and the natural killer cells if those are overactive. All right, my next question is, I've been getting IVIG every month since March of 2015. I had a severe allergic reaction to 3 out of the last 4 infusions and was told I could not get them again. I understand that they really helped build an immune system in me. In lieu of that, what alternatives do I have? And I know that patient had chronic lymphocytic leukemia, which is frequently associated with hypogammaglobulinemia, which is a deficiency in the innate antibodies. Well, when your antibody levels are low, you're more prone to opportunistic infections, whether you get chemotherapy causing that low antibody level or whether it's due to the suppressive effects of the cancer. The CLL naturally suppresses your normal immune system so that it can grow unchecked. And when it does, it can suppress the memory cells or plasma cells from making antibodies, and you become more prone to infection. Now, IVIG is not a therapy per se for CLL. It does not suppress the leukemic cells and does not kill those cells, but it augments your adaptive immunity to fight off infection. So IVIG does reduce the risk of pneumonia, which is why we use it. It hasn't been shown to change the prognosis of the CLL, which is more dependent on the DNA. And so many times you'll see us do next-gen sequencing or DNA analysis by different techniques. Next-gen sequencing being one of the newer ways to sequence the cancer gene. And then we try and target that gene specifically. So that's not immune therapy, that's trying to trigger apoptosis or shut down the replication ability by the DNA within the tumor cell. So IVIG doesn't do that. It simply improves your immunity while it's in your system. It doesn't change your underlying bone marrow. So it's not a cancer therapy, it's to prevent side effects. So the best way to prevent a pneumonia when you don't have the option of IVIG is prophylactic antibiotics, but then you worry about selecting for antibiotic-resistant organisms. And so the alternative to that is hand washing and social distancing. Depending on what infections are in your neighborhood, you take different precautions. So in the fall, we worry about influenza. Then we come into the spring infections, which are usually common colds. They're usually not severe. Then we have a respite. Then the fall, you get the influenzas again, and that cycle repeats. Now that paradigm has changed. We have COVID. We don't know if COVID is seasonal. Everybody thinks it is and hopes it is, and we hope that the sun in the summer will kill it, but it likes the shadows, and it likes hiding, and it likes being passed. It can't get through the skin, but it can sit on the skin. And so IVIG, unfortunately, hasn't been effective against COVID. So right now, whether you got IVIG or not, you need to take the precautions of avoidance to exposures. But there is something called convalescent serum that's being tested right now. So in COVID survivors, we take their serum, look for their IgG antibodies against COVID, concentrate them and infuse them into seriously infected COVID carrying patients to see if that boost of immunity could help reduce mortality. And that's an unknown. It's a belief right now, but the science is too young to know if that'll be effective. Do we have other questions?
We do, Dr. Bear. A couple different questions. Mary S. is asking, any immunotherapies for pancreatic after Whipple with 12 rounds of Forfenax, marker is still 154.
So the markers are, again, a protein that the cancer secretes, but they don't tell you where the cancer is or the size of the tumors. And so I call it the hunt. You wind up looking for where the cancer is, and you look to see if you can use a targeted therapy. Can you do radiation or resection of the one problem area and then give milder chemotherapy as a suppressant? I like to then also look for gene mutations. Many pancreatic cancers that are metastatic, much more than we previously thought, are in people that carry predispositions to the pancreatic cancer. So pancreatic cancer runs in my family, uncles, cousins, and my father. And there is a gene that runs in my family that codes for red hair. You can't see it because I'm bald, but codes for red hair and can code for pancreatic cancer susceptibility. So gene testing for that, some of those genes, not the particular one in my family, but the BRCA mutations like BRCA1 and 2 that are often found in breast cancer can also cause pancreatic, and the immune therapies seem to be exquisitely effective in those patients that have the BRCA mutations. Also, the Lynch syndrome mutations, which are called microsatellite instability or mismatch repair. These are DNA repair enzymes. If you have those mutations that are related to the development of the pancreatic cancer and they persist in the tumor after upfront therapy, then immune therapies are an excellent option against those cancers. So the advice I would have is speak with your physician, and he's probably already going down this road with you, is looking for where's the disease, how much disease, and what are the driver mutations that are making that cancer resistant and active in you.
Phil S. is asking, is immunotherapy effective as an effective treatment for appendiceal cancer?
I think you mean appendiceal cancer?
Yes.
All right, so there are different kinds of appendiceal cancers. There are the neuroendocrine or carcinoid tumors, and then there are the signet ring cancers, and then there are the common adenocarcinomas that behave like colorectal cancer. So some of those, again, depending on the gene mutations, if they're, again, MSI or MMR mutated cancers, immune therapies become an option. However, in those tumors that don't have what I call driver mutations, where you have a gene mutation that's causing them to be aggressive and you have no target or no immune protein secretion like the PD-L1 or PD-1 from the tumor, then immune therapy is less likely or unlikely to work, and you would use cytotoxic therapies like Folfox or 5-FU or Xeloda, capecitabine as an alternative, and immune therapies would be second or third or fourth line treatment.
Ray Voss asks, is immunotherapy limited through trials, or are there any approved procedures?
So many of the immune therapies that I have cited are FDA approved, but they're only FDA approved in certain disorders. That list seems to be getting longer and longer every month. And so in head and neck cancers, immune therapies used to be used as last line therapy, and now they're frontline therapy. So it changes month by month as research gives us guidance as to what's best to use. My colleague, Dr. William Small, from Loyola University, will be speaking next week on one of these Living Well Facebook lectures about clinical research. I would highly encourage participation in a clinical research study, especially if it has an immunotherapy arm, because they're looking at state-of-the-art approaches to try and further responses with less toxicity in disease category that you may be eligible for. So the short answer is many immune therapies are available. And if they're FDA approved, almost any cancer center in the United States has access to those. It becomes a question, is your specific case appropriate for that modality? And if it's not appropriate or off-label, then I would encourage looking at a research study to see if there's a way to incorporate it into the treatment.
Carly Z asks, when and how should you be restaged?
That's a a good question, but a hard question to answer because it depends on both what else is happening in your health, what genetics do you have that you've inherited, what kind of cancer are you dealing with? Is it one cancer or multiple? Is it localized or metastatic? So restaging typically occurs after primary therapy. You then get it reevaluated, and there are different time points for that based on the different stages and types of cancer. An excellent resource is cancer.gov and the American Cancer Society, cancer.org. They can get you brochures and information on what's appropriate for your disease type. And living well, I should say.
Flo D is asking, multifocal breast cancer, node negative, hormone positive, HER2 positive, surgery, chemo with Herceptin, and Perjeta, radiation and continuing Herceptin immunotherapy through November of 2020. Anything else I should ask about?
So Herceptin is a monoclonal antibody. So it was one of the earliest from the 1990s immune therapies of breast cancer. I don't know all the particulars of your case, like what else is going on, but it sounds like you're getting state-of-the-art therapy. The questions become, is it effective? You know, how are you responding to it? And how are you tolerating it? So you always have to remember these therapies carry risks. And we know from clinical trial data that sometimes the treatment is worth the risks and sometimes it's not. And so how much toxicity are you encountering in this treatment, which is quite complex and long-lasting?
Last question, but I believe you might have answered this, just as a general. Is there an immunotherapy for bladder cancer?
Yes, there is. There is a clinical trial right now looking at the addition of a CHEK2 inhibitor and immune therapy in addition to standard chemotherapy and radiation. But that's clinical trial. Off trial, front line, we typically don't use immunotherapy because the chemotherapies and radiation are highly effective. Bladder cancer is one of those cancers where you really want to catch it early because surgery can be curative. And so if there's blood in the urine and they find a bladder cancer, it really is important to do a surgical management first if it's localized. For advanced disease, that's when we get into the immune therapies, the cytotoxics, and the radiation, and you have to adapt the therapy to your own personal situation. Well, thank you, everyone. Be safe, keep your distance, and have a good day.